Hello, everybody. I hope that wherever you are in the world, you're having a good day. Thank you to those of you who are watching, to the organizers of the CSE Symposium for providing us all the opportunity to be here, and most importantly, to our panelists for the important work they do in the area of comprehensive sexuality education, and for sharing their expertise and insights with us today. We're virtual today, first because we're all over the world, but also because the COVID-19 pandemic has necessitated virtual events and has showed us that virtual interactions are not only possible, but can also be successful. While this has certainly been one upside to the pandemic, it's safe to say that all of us, in at least one way, shape, or form, has been negatively affected by the pandemic. In particular, the pandemic has disproportionately negatively affected already marginalized groups, including girls and women, people with disabilities, and people from low-income communities. The first 25 weeks of the COVID-19 pandemic set us back 25 years in terms of the progress made in gender equality and the empowerment of marginalized populations. Millions of girls and young women dropped out of school during the pandemic, in addition to those who were already out of school pre-pandemic. When schools in many parts of the world reopened, girls and young women and those from marginalized populations were less likely to return to school than their male counterparts and those from privileged populations, closing off opportunities not only for themselves, but also for future generations. These school dropouts have forced girls in some countries into early marriage and early pregnancy and increased their vulnerability to STIs and HIV. In Kenya alone, for example, over 4,000 school-aged girls became pregnant as a direct result of the closures, of the school closures between March and December of 2020. Stay-at-home orders have led to increased household tensions, heightening the risk of domestic violence and gender-based abuse. And schools no longer provide the safe space that they once did for victims to escape abusers at home. Supply chain disruptions due to pandemic response has also led to shortages of food and menstrual products. And this has caused some individuals who menstruate to have to reuse dirty products or create de facto products out of potentially unsafe material, leading to an increase in infectious diseases. Furthermore, the lack of privacy at home has also not allowed for those who menstruate to hygienically manage their periods. In addition, food shortages have led some families to using their daughters for transactional sex in exchange for food. And when girls and women attend food or product drives, they're more likely to be beaten by male figures at home when they return home, because these men see the girls and women's attendance at these drives as a public display of their poverty, which then puts shame on the family. The pandemic has put a strain on healthcare systems everywhere, and COVID-19 patients have been given priority in healthcare settings. This means that access to abortion and other critical family planning services has been limited, and this amplifies the risk of school dropout and reifies the vicious cycle of poverty. Whether we realize it or not, these issues affect all of us, and comprehensive sexuality education represents a critical part of the solution to addressing the numerous issues posed by the pandemic. CSE gives learners knowledge about their bodies and how to take care of themselves in order to prevent chronic and infectious diseases. It empowers them to identify the signs and prevent instances of gender-based violence. It enhances their self-esteem and self-worth, thereby giving them the confidence to continue with their education, to set goals for themselves, and achieve those goals. In the long run, CSE has the power to change social and cultural norms that perpetualize the marginalization of marginalized populations. Adequate CSE is not only essential for coping with the current pandemic, but for preventing future pandemics. With that, I would like to introduce our esteemed panelists who have and continue to work tirelessly to ensure that all youth have access to quality CSE during and beyond the pandemic. Rinaldi Ridwan is an SRHR activist and researcher from Indonesia, working to mainstream sexual and reproductive health and rights across different sectors and movements. He has been working with a range of national and international SRHR organizations including the Women Journal Foundation, International Planned Parenthood Federation, Rutgers, and Johns Hopkins Center for Communication. He is the co-founder of the Indonesian Adolescent Health Association. Rinaldi is currently doing his PhD at UNSW Sydney on adolescent sexual and reproductive health education in Indonesia. In the past 6 years, he has been doing consultancy mainly on qualitative research and health communication around adolescent health and rights for UNICEF, UNFPA, WHO, ARROW, Rutgers, government agencies, and the private sector. Rinaldi was a co-chair of the Global Youth Forum 2012, a part of the ICPD operational review process, and a member of the board of directors for Youth Coalition for Sexual and Reproductive Rights. Ahmed Ali is an Egyptian physician, public health professional, and researcher. After 10 years working in sexual and reproductive health programs, Ahmed obtained his master in public health from the American University in Beirut in 2016. He then served as a research fellow at the Faculty of Health Sciences and as a medical education fellow at the Faculty of Medicine at AUB. Ahmed's most recent projects involved exploring the use of gender transformative approaches in humanitarian settings, mapping and developing SRHR professionals' social and behavioral competencies, assessment of intergenerational communication about SRHR topics, integration of SRHR services into primary healthcare, and the impact of COVID-19 on the access to SRH services. Currently, Ahmed serves as an adolescent sexual and reproductive health and rights consultant at the World Health Organization. Marie Mercy is a Kenyan youth advocate. She is the president of the Nairobi Youth Advisory Council, a member of the Tausi Task Force and Empower for Change under LVCT Health, and Love Matters Kenya youth advocate. Ms. Mercy is a sexual and reproductive health advocate for adolescents and young people with experience in HIV prevention and care treatment from her work at a hospital, as well as advocacy for young people living with HIV on a local and global scale. Through community engagement, training, and social media, she raises awareness. She spoke at the ICASA conference in 2022 and is currently a youth representative for the Mosaic Project in Kenya. So we have a great lineup of speakers today, and I'm very excited to introduce our first panelist, Rinaldi Ridwan, who will be speaking on a high level about the state of CSE in the Asia Pacific region during the pandemic. Rinaldi, over to you. Rinaldi, sorry, you're on mute.
Okay, thank you so much, Pepita. I'm too excited for my panel. So I would like to share about the research that I've been conducting with my colleague from ARROW, Asia Pacific Research and Research Center, and with YPIR from last year on the status of CSE in Asia Pacific region. So this is actually a bigger study, not only one study. It's a bigger study to really see how CSE is being implemented in the past 20 years. So it starts with a systematic review on how it has been implemented in Asia Pacific, qualitative study, and then the quantitative study. So, but for today's presentation, I will take some snippets from the qualitative study. So the background was Asia Pacific is the most diverse region on earth, if I can say. There is high income countries, lower middle income countries, and then least developed countries. And then aside from that, there is diversity in terms of religion and culture from this region, which makes it as the most diverse region on earth. And this diversity provides consequences on young people's health, including advocacy to advocate for young people's health, including for CSE. And then when we talk about sexuality education and efforts for advocacy in this region, presence in diverse from across the region, ranging from lobbying policy, evidence generation, peer education, and lots of different approach. So the aims of this bigger study is three, actually, to identify enabling factors for CSE fulfillment, and then use identify specific factors in using intersectional feminist approach for CSE advocacy, and then scale up potential strategies for advocacy and global norm setting in with a focus on CSE implementation and policy. So the methodology, this is from the qualitative inquiry from the bigger study. We present the qualitative inquiry. It includes 34 informants of in-depth interview, consists of young people under 30 and adult working with youth serving organization across Asia Pacific, and then it involves 18 countries, which include all sub-region: South Asia, Southeast Asia, East Asia, Central Asia, and the Pacific. So based on this qualitative inquiry, we found that there are some situations that pretty much match with Pevita has mentioned in the beginning about young people's SRHR situation. First of all, marginalized young people face more significant challenge during pandemic, such as domestic violence among LGBTI youth, young women, and young people with disability, because with increased tension within the household, then domestic violence has become something that is pretty much inevitable throughout the pandemic. And then there is increased vulnerability to online gender-based violence with the increased dependency towards social media, towards the internet throughout the pandemic, and so does the vulnerability to online gender-based violence. And then it has been reported and observed by our informant, there is a significant increase of online gender-based violence. At the same time, with the closure and then with the restriction of access to health services, there is also limited access to health service and contraception. And then also, as mentioned before, there is increase in terms of child early and forced marriage and union throughout the region during this pandemic. And then what we also observe is there is shrinking space during the pandemic for CSE. So this is the situation before and during the pandemic. Before the pandemic, before we start, CSE has a lot of variant terms across the region. As we observe, there is this term of reproductive health education, HIV education, life skill education, and then respecting relationship education, all these terms. And then it is available actually in different forms, such as insert in the school curriculum, such as in biology, counseling, and sports. And then that can be inserted. On the other hand, it can be a standalone subject. And then in some areas, it can be under extracurricular, such as Scout or the Red Cross. And we found that a counseling teacher plays critical role for engagement, because they are the one who has been knowing about sexuality education throughout their education, and then during their placement at school, they found lots of cases related to SRHR. And what happened during the pandemic, CSE has been sidelined in most of the countries due to the prioritization of core subject, because the school usually operate, like, for example, 6 hours, and suddenly it has to operate full online, and then it can't operate 6 hours just like before the pandemic. So the teachers has been prioritizing core subject rather than those who are containing CSE. And then there is also issue with the internet quota, because not everyone can have access to the internet. And then CSE, sexuality related materials, is not priority teaching. And with regards to extracurricular, since it is really something that is out of the main subject, has been affected significantly and inactive at some school. That from our informant, the information related to CSE is no longer exists throughout the pandemic. So, what about the situation for advocacy? We found that there is wide consensus that CSE is important among public and the government. Like most of the people will be agreed that we need CSE for young people. However, the issue is there is shortage of technical knowledge and expert to guide CSE implementation. Like when we talk about SRHR, lots of people who are working on this field, but then when it comes to very specific on CSE, there is really shortage of technical knowledge. And then aside from CSE advocacy, because everyone, like most of organizations, try to advocate to include CSE in the education system, in the school subject. On the other hand, there is lots of other organizations who are trying to also include, such as climate change, anti-corruption, disaster preparedness. So everyone tried to influence the educational system at the same time. So yeah, there is pretty much competition to include this in the school. Then there is issues of medicalization of CSE, because organizations who are working with CSE try to tend to work with Ministry of Health rather than with Ministry of Education, and then young people's sexuality being seen from mainly from the health and medical perspective rather than from educational pedagogy. Meanwhile, when we talk about CSE, it really closely related to the educational system, how it's it is being presented in the educational system. And we found that most of the organizations who advocate for CSE is a single fighter. There is no other actors in their settings, and then this makes them like of intersectional approach. Like for example, it is mostly from a service provider organization, so they have no idea on how actually the educational system are running. They have no idea on how law system are currently running and how it can be influenced to insert specific materials into the school. And then we found as well that young women participation is pretty much hindered. There is increased young women participation for advocacy, but then within the movement itself, there is lots of hindrance, such as the dynamic between young women and between older young people to younger young people, and then young people between the adult. And then from all this dynamic, young women is the most significantly affected in terms of access to advocacy. And then with the issues of federalism and decentralizations, it is pretty much difficult to advocate for CSE in one country, because then you have to go to the local government one by one, then go into the national government. And then when we talk about advocacy, the agenda, it is mostly ad hoc. So what is needed at this time, rather than thinking it from strategic approach, that how can we really strategize CSE in the educational system. And during the pandemic, we found a new pattern, like there is digital inequity among advocates. Those who have been working who have been well versed in working online before the pandemic, they can really thrive throughout the pandemic. Like they can join lots of different meetings through Zoom and different platform, and then they can really navigate the space. But for those who are not getting used to online working modality, they really struggle and on doing the advocacy, because they have no idea on how online advocacies are supposed to be. But the thing is, there is also positive side from throughout the pandemic. Even though some data confirms the other one, the other way around. Like for example, pandemic enable greater participation for disabled young people. Because disabled young people usually have no access to advocacy, like because of the accessibility, because it is outside the city, and then it's hard for them to do mobilizations. And suddenly they are able to join different advocacy avenue and meeting, which makes them realize that, oh, there is actually lots of space so far, and then throughout the pandemic we are able to access and claim this space, and then also including those in remote area. So during this situation, there is also some innovation. I mean, with all this challenge and limitation, we actually make some several case study, but then there is one which is specific related to pandemic. It is from Nepal, with its high adaptability and resilience throughout the pandemic. Because as we found, the pattern is CSE advocacy and implementation has been sidelined, but advocates in Nepal has been really doing some creative approach, such as they try to change everything into online. But then when we talk about online, it's not only about internet as well, but then they are utilizing other media, such as radio program broadcast into remote district, something that is not possible through online, but then they've been using traditional approach through radio, and then it can reach young people in the remote areas to ensure that access to CSE information is available to them. So this is critical strategy that we have concluded based on the study from the multi-method study, from the systematic review, quantitative and qualitative, that that can be implemented to advocate for CSE during pandemic and then the post recovery setting. First of all, it is important to really evidence to do evidence generation, to have a strong research about how CSE is should be put in the agenda, and then how to put it in the educational system. And then second one is, it is important to maintaining a good strategy for partnership, like building a good rapport with the government, and then with the with different government agency. And then it is important to insert CSE materials on the CSE materials in the school curriculum, and then it is important to really build consensus with with people from other movement on how we can really build solidarity rather than doing competition among with other movement. And then communication awareness raising strategy is important, like raising awareness through the public campaign about CSE. And then we found that sufficient and continuous training for anyone involved is needed, because sometimes there is a high turnover rate for those who are advocating for CSE, and then continuous training is really needed. And involvement of young people, including mentorship, is also needed, because young people sometimes have no idea about how they can navigate the space, because of sometimes there is already adults who have been in the field for years, and then young people have been there for just a few years. So a mentorship is really needed, and advocating for supportive policy environment is important. The next one is provision of digital CSE. It has been evident that digital CSE has been has been available in a lot of in most of countries, and then in each countries there is many intervention on it. It can be from the government, can be from the NGO, or from or organic from the community, or any individuals who have concern related to CSE. And then it's important to maintaining network or task force for advocacy rather than just being a single fighter. And then parents has been neglected in most of the advocacy, like it is mostly between the school, it is mostly between the government, but the parent has been left behind. So it's really important to involve them, and then also as well as the teacher, and then to strengthen advocate capacity in adapting to online work modality, because not everyone can do online work modality. And it's also important to monitor resistance to SRHR, both traditional barriers and emerging organized opposition. In our other study, we found that organized opposition related to CSE is mostly found in high-income countries such as Australia and Japan. Meanwhile, in lower middle-income countries, it is mainly from traditional actors rather than, and then it's not well organized compared to those in high-income countries. So what about at the regional level for advocating CSE? So it is important to adapt to online working modality, as I mentioned before. And then leadership workshop is really important for young people and then for advocates working on this. And then it is really important to build relevance on CSE and SRHR, because sometimes when we talk about CSE at the regional and international level, the mechanism will be ICPD, but then there is other mechanisms such as Sustainable Development Goals, Asia Pacific Forum Sustainable Development, and other regional international process. And it's also important to still maintain and strengthen awareness about ICPD mandate and agenda, because CSE has a strong roots from the ICPD from ICPD PO in 1994. And then to do online campaign is still necessary and then needed for the regional level. Technical assistance is also important, and then the last one is address exhaustion from online working modality, because everyone is working online, but then and then everything most of the thing will be solved through the online online meeting. Then addressing exhaustions from this working mode will be important for advocates to work in the coming years. Thank you so much.
Thank you, Rinaldi, for such a rich presentation and for providing that high-level overview of what's going on in the Asia-Pacific region. Your presentation touched on a few really important themes that our next two panelists are actually going to talk about. So next, I am excited to introduce Ahmed Ali, who is going to be talking about how to translate curricula from in-person to remote such that it's accessible to all students. Ahmed, please, the floor is yours.
Thank you so much. So that is true. I will pick up from where my colleague Rinaldi finished. He mentioned a lot about the different challenges and the different strategies that could be used in advocating about implementing better CSE interventions. And in our study that I'm going to share with you, sorry, it will take just a second probably to display. Sorry, it took long. I assume that you can now see my screen.
Yes, thank you, Ahmed.
Yes, perfect. So building on the previous presentation, in this study, we are trying to provide some lessons learned from adaptations and CSE education programs that were implemented during the pandemic. And these are the results of case studies that were gathered from 5 countries by a team that included young people, experts, and young experts as well. So my name is Ahmed Ali. I will be speaking on behalf of my colleagues. This study was built on a report that was published by WHO and UNFPA. The title is very suggestive, not on pause. So services shall resume. Although, if you recall, at the very beginning, times were scary. There were more focus on economic crises. Health was not the greatest issue. And by health, I mean sexual reproductive health. And even in that, adolescent sexual reproductive health services were mostly ignored. So this technical brief tried to sensitize guidance from lessons learned in other humanitarian settings. There were still no lessons that were gathered during the COVID pandemic era. So based on that, we tried to reach different organizations with the help of WHO and UNFPA regional offices in order to see what actually do the organizations do. So we prepared the framework, tried to make it very simple in order to receive submissions to cover wide regions. And we engaged a team that were able to engage with those organizations. And then we did our analysis. And these are basically the findings of the whole study. So we had 36 case studies from 16 countries that covered the main services for adolescent sexual reproductive health, including access to contraception, ministerial health, HIV care, HPV vaccination, and of course, sexual and reproductive health education. For the sake of this presentation, we're focusing on the synthesis related to CSE. So here we go. Regarding comprehensive sexuality education, the 5 case studies that we are discussing coming from India, Philippines, Myanmar, Namibia, and Zimbabwe. Target audiences for those case studies were mostly school-going adolescents that were forced to stay home because of the pandemic. And then those organizations tried to add also out-of-school students because now the means of the adaptations could actually try to reach those as well. Some programs try to focus on adolescents living in remote or rural areas, and also others try to focus on most vulnerable adolescents as well, because they wanted to mitigate the impact of COVID on their access to information. So similar to Rinaldi's presentation, what happened prior to the pandemic was that these programs were curricular based and they were provided in schools as part of the curriculum. But also in other countries, and I'm not here commenting on the quality of CSE programming, but these were the modalities that they were provided. So some of them were provided as sessions in youth clinics. Some of them were provided as part of a youth-friendly corner activities. But basically, most or all of these programs were actually provided in person, being facilitated either by teachers or other professionals and maybe peer educators. During the pandemic, and this happened in delivering many other services as well, and also some other education programs. The main modality of providing information or sessions were reverted to being online, which is understandable. Two ways of online provision of material were asynchronous and synchronous as well. So self-guided use of online material or facilitated, sessions that used social media or meeting applications such as Zoom or others, and maybe a combination of those methods. So this maybe impacted the quality of the program. Some of the programs tried to resort to a lighter version, so they were not able to provide the program in full, and they focused on the informational aspect, which was easier, to deliver using these modalities. Okay. This doesn't mean that in-person delivery of the program stopped. So in Myanmar, there was a chance that these programs were able to be provided in schools, but with a reduced class sizes. So they complied to COVID safety protocols. They continued, their activities. There were just this small adaptation that were made them able to resume their activities. In Namibia, and this was one of the issues that was also mentioned, because of lack of access to the internet in some regions, they actually tried to focus on outreach activities. So peer educators were sent out, of course, while complying to safety protocols, and had sessions in their communities because of the lack of the internet access. Again, I'm not commenting on the quality. I'm just commenting on, the reasons needed for these adaptations. In Zimbabwe, and this is a more comprehensive example because there was already a program in place that actually wanted to target school adolescents and also out of school adolescents that was being ready to be implemented before the pandemic. So UNFPA, UNESCO, and the Ministry of Education were trying to adapt their program into radio lessons. So interactive radio edutainment lessons, and this may be the only example that actually tried to implement the program in full using an alternative modality. So the sessions were included informational aspect, skills aspect, different dialogues for attitudinal aspects, so not to miss any of the outcomes of CSE programming. And finally, one of the adaptation was not related directly to CSE programming, but actually was related to the impact of COVID-19. So the programs were used as a window to promote information about COVID-19 pandemic, to combat misinformation and to provide information about safety and also referrals if needed. In addition to that, and this was a finding for most of the case studies, even within the other themes, there was programs that added a mental health component, again, because of the impact of the pandemic, and it seemed as a priority. So this mental health component was either presented as information or presented as referral to the needed services. So in terms of implications for action, follow-up, basically our recommendations for next steps. We think that from these examples, and we didn't actually discuss the whole spectrum of sexuality education, we focused on CSE, but there are many other examples that used online education, used specific dedicated websites, used health apps, etc. So there could be a wide variety to learn from. But even within those that we discussed now, there was a diversity of audiences. There was implementation in different contexts, whether there was at the time COVID restrictions or not, etc. And these may provide us the chance to learn and provide learnings for future either circumstances similar to the COVID pandemic or even to be adapted to other humanitarian contexts. And these could be, also implemented in different resilience programming or for other similar contexts, such as low middle income countries as well. It might be early to judge these programs, especially that at the time of these case studies, we were not having a lot of data of follow-up or more specifically evaluation. So in the bigger spectrum of CSE programming, there maybe have been evaluations now for use of innovative and resources that could be delivered remotely or to assist the main school-based programming. But on the other hand, there have been no evaluations in this specific context. So it seems only logical that we need to evaluate those interventions. And then based on the learnings, we could see their potential and if could be accomplished in either complementing an actual existing program or even substituting it, and if that would be efficient cost-wise as well. From our side, and this is the final point, we are actually planning on a second phase of this case study, which would inform us, after 18 months of those findings, what did happen with those innovations? Have they been maintained, sustained for a longer term? Have they been adapted even further? Have they been dropped, and other means have been used? Have they been evaluated as well? So basically, we had a snapshot at early in the pandemic, and we need another snapshot in order to try to see the findings at a later phase and how they could help us, in generating better evidence to help us, during the pandemic and going on forward as well. Thank you so much. Over to you, Bavita.
Thank you so much, Ahmed. That was amazing and really fascinating. Awesome. And now, last but not least, I'd like to turn it over to Marie, who will be talking about community engagement and young people as representatives and engaging communities at large. So Marie, over to you, please.
Thank you so much. Let me just try to share my screen. We are able to see it.
Yes, thank you.
Oops, sorry, what is that? Okay, I've lost it. So I have said I'm Merci Bishaho, presenting about how we use community-led engagements to just engage young people, parents, the stakeholders, to just make sure that they have information on how best they can learn and just have general information on CSE. So these are the authors. But basic background on what I think I don't really need to go through this because Pavita had already shared this, but just to bring you up to scale on what the data is on how young people are and just a scope, general scope on what there is in Kenya. Adolescents and young people face a lot of challenges, and these challenges are mostly between 10 to 24 years. And it accounts for 33.8% of the population in Kenya, which could actually be higher because there was another census that was done last year. So this number could have actually gone higher. And you find that 42% of the new HIV infections are among this age group, which should be alarming because it is almost a quarter of the Kenyan total population. And you find that after in Kenya, girls who are within 19 years, about 4,000 of them got pregnant, and it's because of the lack of comprehensive sexuality education. And this is because it's a controversial topic. It's provided on small scale, and it's just done by very few people. Some very few civil society organizations are able to provide this information because it's taboo. It's taboo, like it's not allowed. It's not a comfortable topic, and people are not comfortable even accepting the information itself. And also you find that access to contraception is difficult. And this was heightened even with the onset coming of COVID-19. So you find that the challenges are excavated. There was an increase in GBV, there's an increase in STIs, and also, as I had earlier said, that there's an increase in HIV. And the lack of supportive policies and opposition from faith-based organizations. And in Kenya, actually, there's a lot of cultural practices that are happening. These all together combine to make sure that they act like a barrier for provision of CSE information within the community, and even for mostly for school-going kids, because there are no policies that allow you as CSO or a young person, a youth advocate, to go to the community or to the school to provide this information. So this is what my abstract was just based about, to demonstrate how, if properly delivered, CSE can meet the demands of empowering young people to be able to make informed decisions about their relationships, their sexuality, and just navigating how the world is. There's a lot of discrimination, there's gender inequality, there's a lot of unintended pregnancies. Just make sure that they are able to provide and make informed decisions concerning their lives. So the method that we used here is we used a peer-led model where we had 20 peer educators who are from those communities where they were going to be placed in. We worked with community champions, and we mostly targeted to do in-person dialogues with the adolescents who are between 15 to 24 years, and in all the diversity. It was not just for the cisgender or homosexuals or hetero people. It was an inclusive process where we just had a diversity of all young people available within the community, so that we just get a wholesomeness of the information that we are going to provide. We're also getting the challenges that they face, because sometimes we think for ourselves instead of engaging them. And also we engaged teen mothers and teen fathers, and the mobilization was done within 10 sub-counties, and the champions, we have champions, and we also have the Youth Advisory Council members who are the ones who are spearheading this process. And also we took to advancing access to and the provision of essential components of age-appropriate CSE, and the challenges that they pose to its delivery due to their negative attitudes and personal values. Their dialogue. We also included engagement with parents, religious leaders, community gatekeepers, and the decision makers, because they are essential in this process. The decision maker here is the person who makes the policies, so they are crucial to this process. The parent is a hindrance for the young person if at all they maybe decide to, maybe they are found with a condom at home, or they are found with maybe just a general knowledge. If they have decided to go for a contraceptive at a facility, these parents are becoming hindrances because they lack information, which is why it was necessary to include them in the dialogues. And then also the model emphasized on attitudes and value transformation. We're working on to shift from knowledge imparting methodologies, and also just make sure that the techniques are adding value. And also we make sure that we are tailoring these activities to a point where it's client specific. I think Ahmed would call it human-centered, but we're just looking to make sure that we are engaging them at a personal level, at the community level, at grassroots level. Most of the engagements happen on the higher level, so engagement with young people starts. So after that, we agreed that on a standard package of information, because as again I said, policies are limiting. So we just agreed on what much we can provide. And the county and the sub-county supported us to get partners, because without resources, there is basically not much you can do about it. So there was the county who supported us with partners, and also the documents and tools that we used to collect this information, and how just basically assessing if this process was going to be beneficial, or if we would need to change the tactics that we were using, or if we needed to scale up. And also how the services, the county also helped in providing the service providers for those who are going to access the services. And then the acts, they were responsible for mobilization because they're the ones who live in the community. They would know where to get these young people. They would know how best to engage them. And also where would they be comfortable to go, because we need to create a safe space for them to be able to just open up, because if they don't trust you, then they will not give you any information. If they don't trust you, they also will not listen to whatever you have brought on the table for them. So this is what we had in mind with them. And this is actually what worked, because they were able to trust us and able to feel that I am going to be confidential with the information that they are going to tell us, because most of them, they were very honest, if honest was the word. They opened up on the challenges that they're facing and how CSE information was helping them in terms of knowing what to do, in terms of knowing if at all I met such a situation, what solutions would I have as a young person. Some of the findings were that incorporating age-appropriate, accurate and non-judgmental sexuality education into the peer-led model encouraged the AYPs to make informed decisions about their health and their future. And it was demonstrated by the number of young people coming to the facilities, because we had also engaged the service providers. So they know that whatever they're coming to share is confidential. No one is going to discuss them. You would come to a facility and you find that the person who is serving you is a friend to your mother or is a friend to your aunt, and they will go tell them, oh, I saw X person come to the facility. Has she started engaging in some risky behaviors? So they were assured that whatever service they have come to get is confidential and no one is going to infringe that. They also sure that they're coming to get a service that is actually there. And then there was also that we were with this we were able to reach 3,000 AYPs with accurate information, age-appropriate sexuality education, and also COVID information. We live in a rural setting where information is hard really to get there, because there's no technology. They only listen to, I think, radio and they don't have access to smartphones. So information is very limited, and understanding, not all of them are literate. So we bring COVID information with integration of the CSE studies, so that they're able to tailor information, able to understand at their levels. And then also we working with the 20 peer educators. We supported 2,400 AYPs to access reproductive health services, including the contraceptives, family planning, HIV testing, because we also did testing services and sharing of self-test kits, and also mental health services. COVID brought a lot of challenges, including the stay at home. Schools were no longer available, where young people would get maybe at school they have counselors, but at home there's no one to do that. And the parents have lost their jobs. So where are they going to offload these problems? Where are they going to tell? Who are they going to tell if they have a challenge? So we brought around this to them, so that they feel they are assured that they are not crazy and they're not wrong to feel the way they are feeling. It's more or less like an assurance. And also we provided a supportive environment for which young people felt comfortable expressing their opinions and their privacy and confidentiality. I think I had mentioned that they were respected and their boundaries. And also from this, the AYP cited the challenges they faced, including getting contradictory information, the lack of safe spaces to speak about sex and sex-related topics, because these are taboo topics within Kenya. And then there's also discrimination and judgment when seeking RH services, especially to the sexual minorities in Kenya, because they're also not covered for in the constitution. It's against the law. So most of them, they're usually judged and discriminated against in the facilities. Also, the inclusion of parents and the community gatekeepers assured the AYPs of an enabling environment, and they felt supported to access the reproductive health services. Adolescence and sexuality must be demystified, and communities, more or less, this is more or less like a recommendation. Communities practicing sexual and reproductive health and related skills, and youth participation in program design, implementation is often placed to reach their peers. This model showed that if you give young people an opportunity, and if you're able to just probably allow them, they can be able to deliver some of the messages that become difficult for the adults to do, because they don't have that relationship with the young people. They don't know what the young people are going through, but if you allow the young people, they are able to help, even just provide workable solutions for their own situations. Like in this case, we were able to provide CSE information, and the young people were receptive to this. They were able to accept and understand what the information that we were giving them, and even able to use it after. And then and finally, a CSE can be scaled up among a variety of within the communities, and also ensure that you involve other stakeholders. We were not able to involve other stakeholders because they are not willing to join in, but with continuous engagements, we can get buy-in from other stakeholders, especially the faith-based organizations, and including also some of the community members and maybe some teachers. And basically just have everyone on board and just make sure that the young people agenda is all of us who are doing it, not just a one person things. And I think that is it from me. Thank you.
Another fantastic presentation. Thank you so much, Marie. And all of you are touching on such important themes related to CSE implementation and delivery. So we have a few minutes in our session, and I would love to hand it over to each of you to ask questions of the other panelists. So did anybody want to start?
I would want to ask Rinaldi. I had seen that you were able to monitor resistance. I think that is something us in Kenya have not been able to do. We just know that there are people who are resisting CSE, and they have things they don't like about it. So how are you able to do this? I would really love to learn how you are able to do that.
If I can understand it correctly, what you mean is to respond to the resistance towards CSE in the Asia Pacific context, is it, Marie Mercy? Yeah. Okay, so in responding to that, actually, it is part of the other study that from the systematic review, that resistance is there. Resistance is there, as I mentioned, in the setting of lower middle income countries. It is mostly from traditional actors such as religious leaders or community leaders. In responding to that, actually, there is no person, no entity which I can confidently say there is against 100% against towards CSE. Actually, it's nothing. And based on my previous experience so far in the Islamic context, actually, like for example, in the Islamic teaching, some part of the CSE is already embedded in the Islamic teaching, such as menstruations, puberty, wet dreams, and then how male and female are supposed to mingle in social life. But the thing is, when it comes to the resistance, it's usually when people have no idea what are the materials in the CSE itself. In responding to this, some teacher really open the dialogue with the person who are not agree with the CSE, and then tell them, so this is what are included in the CSE, and most of the time they will be agreed that, oh, it's really important. However, there are some red flags that people who are against CSE not wanting to cross into it. It's the topic around LGBT, topics around contraceptions, topics around abortion, or even topic around gender. Like some people have this belief that the topic around gender should not be discussed because male and female have already have their place on the society and based on religious teaching. So there's no more negotiations to it. Thank you.
Thank you so much.
Sorry, great. Does anybody else have questions that they'd like to ask the other panelists?
I do have a question for Marie. It's a two-part question, or two questions, let's say. So the first question is that you mentioned, cooperation or collaboration with the county or the sub-county. that provided you with some resources and some tools. I wonder if that, changed during the pandemic. So, or was that implemented during the pandemic? So basically my question is about the nature of collaboration between you and the county and if it changed because of COVID-19. And the second question is that these engagement activities seems very important and crucial, but from your perspective, what is the outcome that you would like to see based on these activities? And also, what could be the impact of COVID-19 pandemic on this outcome?
Um, Thank you so much for those questions. For starters, on the resources, before the pandemic, these are activities that are mostly left for the CSE, so the civil society organizations to do. The government does not take part in such because as they have not really endorsed CSE. So they don't readily agree to this. But during the pandemic, we were able to prove to them that this is something that is essential for young people, and they brought around so many resources, including even them offering the healthcare providers at facilities, giving us commodities to take to the communities because the young people were not able to come to the facilities, so they gave us the commodities to take to the young people in the communities, even providing logistical support in terms of the persons who will go there. So they provide transport, airtime for those who will need to be called, even as maybe a small stipend for the ones who would work throughout that period of time. So they were really helpful, and also engaging them showed them that there is need for a policy change, or more or less a policy review from the policy documents that you already have within the country, so that they are able to include some of these essential topics and some of these essential information for the young people to access this. So we can say the collaboration really kind of helped upscale and improve the results that we were looking to get when we started this process. As for what the outcomes we were looking to get, I think the reason we were doing this was just make sure that young people were able to make informed decisions, which we got. But I would wish on a larger scale that it can go to schools. We're not yet able to do that. It's very limited on on the amount of things that I would want to go tell a young person, maybe like let's say a 13-year-old, a 15-year-old. I have limitations that are policy levels. There is limitations on the parents. They would ask you, what are you telling my child? Why are you teaching them these things? So in such situations, we still have limitations on those areas, which I would really wish that we are able to figure out a way that we can incorporate everyone's concerns, because they are concerns which I totally understand from me as a young person and from them as the parents or as the church, or from whatever angle that they're looking at it from. We totally understand, but we need to find a harmonized and a level where all of us are looking at the interest of this young person. I think that is my greatest wish for us in Kenya in terms of CSE.
Absolutely, completely agree with prioritizing the young person. Great. Any other questions? All right, I will take that as a no. So thank you again all so much for your time. Again, we've touched on a lot of really critical topics in the implementation of CSE, from how to engage community members, how to prioritize the needs of our young people, how to engage out of school students, what CSE is looking like in different regions. So I greatly appreciate all of the work that you all are doing in the area of CSE. As you all are able to tell from the work that our speakers are doing, we have come such a long way in terms of effective implementation of CSE and advocacy for CSE. but our work is not done. We still have a long way to go. And this is going to be the first of many such conversations, or among the first of many such conversations that we have about this topic. I hope that next time we have such a conversation, we'll all be in person. But in the meantime, I just want to thank our esteemed panelists once again for the work that you're doing, and to the organizers of this symposium, and to all of you for watching and for your passion for CSE and your interest in CSE. So with that, I hope you all have a great rest of the day, and I thank you for your time.